Okay, next we have Greg Bisson from Medicine and Epidemiology.
Hi, everybody. Thanks so much for the opportunity to speak today. Thank you. So in 2025, there were 10.7 million TB cases and approximately 1.2 million TB-associated deaths. And we often think of TB as a disease that is an infection. They present and they can be treated. But what is underappreciated is approximately 60% of people, over half, have chronic scarred lungs resulting in impaired lung function after treatment completion. And the idea that patients with post-TB struggle is really illustrated by the fact that when you look at TB patients who've completed therapy successfully and they're compared to comparable community-based controls, there's approximately threefold increased hazard of mortality. And one data set that I think is really shocking is that when we think about TB as a treatable infection, they're done with their treatment and their treatment is complete, approximately half of all health loss due to TB is from post-TB sequelae. So it's something that sticks with people long after they're treated. So there are an estimated 155 million TB survivors living in the world today, indicating this is a very important public health problem. So as the medical director for Philadelphia Tuberculosis Control, I've seen hundreds of TB patients over the past several years, and I can tell you that I worry far more when a patient comes in about whether or not their lungs are going to heal than whether or not they're going to fail microbiologically. Microbiologic treatment failure in tuberculosis in our setting and in many places around the world, including in Botswana, is very rare, whereas destroyed and impaired lungs is very common. So one thing I ask clinically is who's going to get better? So this is pre-treatment and post-treatment scans from 2 patients. So this patient was treated for TB, and for whatever reason, this huge thick-walled cavity looks a bit ominous when you start treating them. It's almost completely gone away, leaving a small scar. Whereas this patient had bilateral disease, has some aspects of their lung heal, but is left with cavitation and bronchiectasis. That is a bad place to be because this is essentially an open portal to the world and contributes to chronic inflammation and post-TB lung disease. So in my research life, the questions I ask are very clinical, but use translational methods to try to solve these. So which patients have non-responsive TB and why? We're trying to define phenotypes of TB that are focused more on treatment response and less on initial presentation. So we're using translational methodologies to try to sort this out. So can you tell when patients present why some patients get better and why some patients don't? So in our studies in South Africa and now in Botswana over the past decade, we're using translational approaches to try to characterize, for example, lesion maturity. This is not an FDG PET-CT scan. That PET scan is radio labeling immature type 1 collagen. So we're trying to look at specific lesions to say, is there differences in lesion maturity which may predict whether things are going to resolve? Because fundamentally the question is, if you could identify patients who aren't going to get better when they start TB treatment, with just TB treatment alone, the other patients should be enrolled in clinical trials of adjuvant therapies. But what therapies would work? So we're using sputum transcriptomics comprehensively on over 250 patients in Johannesburg, South Africa, with longitudinal assessments over time to try to find immunologic profiles that predict response to therapy and non-response to therapy and identify candidate therapies, which are hopefully already FDA approved. This is my final slide. So what are we learning? There are different phenotypes of response. So this is FEV1. It's a pulmonary function metric that's associated with survival. This is time, and we're following patients from treatment initiation to 6 months after treatment completion. If you're further down here on the Z-score scale, your lung function's worse. So not everybody is the same. In fact, they're shockingly different. Some patients never really have a problem with lungs. I don't know why they tolerate their TB in a different way than others, but we're trying to figure it out. Other patients have loss of lung function and some have healing. So we hypothesize that these will have different immunologic profiles and may require different therapies. And if we can identify who they are at the outset, we'll be able to propose clinical trials. We're also learning about important phenotypes of TB that I think are somewhat underappreciated. So this is a complex graph, but I think everybody can see there's more blue on the top and more red on the bottom. So what we're comparing here is HIV-infected patients, which are on the bottom part of the circle, to HIV uninfected patients on the top. More red lines mean they tend to disseminate inflammation from their lungs to their circulation. So there's positive correlations between biomarkers in sputum and blood. Whereas with HIV uninfected patients, the correlations tend to be negative. We hypothesize this is a phenotype associated with spilling inflammation systemically, chronically, perhaps due to impaired pulmonary function, epithelial barriers. So in summary, our research is trying to take the power of all the translational research potential that is all over University of Pennsylvania and bring it to this important question about TB to try to focus on the types of outcomes that people really care about, which is whether or not they can breathe, live, and function a healthy, long life. Thank you.